Thank you very much, Drs. Tien and Brew. So let's get going, because I tend to be a bit of a talker and I like to have a lot of slides. So all right, so these are my disclosures. So I showed this slide last year, I think it was, when we had the session with Peter Hunt on inflammation, but I think it still is a good slide that warrants starting the presentation with it. And that is both from a clinical standpoint and a research standpoint. We have to remember that there are, of course, different phases of HIV infection, and when we're investigating it or when we're managing someone, you know, we pay attention to that. In the clinic, it's very obvious. In the research setting, I think it doesn't always get as much attention as it deserves. So before infection, there are host, drug, and pathogens that can affect the central nervous system. We've known that. Alan Winston has done a fantastic job with collaborators, and others have as well, at pointing out that these factors can affect the central nervous system even before someone gets infected with HIV. After infection, those factors are still there. There might be some enrichment for people who use more drugs, who have a greater problem with addiction, because those people have more risky activities that could put them at risk for getting HIV. But once that happens, then we have to worry about immune suppression, of course, and HIV replication and other factors. So when people get linked to care, we're doing so much better at that than earlier in my career. They get started on antiretrovirals pretty quickly, and we are able to reduce HIV replication, if not almost eliminate it. So I changed HIV replication to HIV RNA here to reinforce that these may be transcripts and not actual replication. And those are being produced, as well as neurotoxic proteins. So transcription and translation are continuing even if there are no intact viruses. And those still have immunologic consequences. They still have neurologic consequences. And we also have treatments for viral hepatitis. And while we can cure hepatitis C, not everyone who has active hepatitis C is getting curative therapy, but we're working to do that. And people who have hepatitis B, the field's working towards hepatitis B cure, and we have treatments that can keep it in check, but it's still we're still not able to cure it. And so can be a long period of clinical stability during which some of these factors, including the social and structural factors and genetic vulnerabilities that have been touched on yesterday, can continue to put people at risk for problems. And then while we're all here, we have, we think, premature aging. And so age-related comorbidities like diabetes, like vascular disease, start to become a problem, and the medications we use to manage them can lead to polypharmacy and additional problems. So the first question I just wanted to put forward is, how do HIV and antiretroviral drugs influence the risk for cognitive impairment and other neuropsychiatric conditions during virally suppressive therapy? And if you'll forgive the neologism here, I took the undetectable equals untransmittable, but asked the question of whether undetectable equals untranscriptionable, and it does not. And this is a slide that just summarizes some very nice work from Paula Desplots on the left, using brain tissue from the National NeurAIDS Tissue Consortium of people dying with HIV and who are on antiretroviral therapy, and showing basically that there are substantial differences. I want to use the laser, is it? I can't see it. So, so anyway, on the upper left panel there where it says DNA, what you can see is that, okay, there we go. All right, DNA, there are some people who have almost no detectable DNA in their brain at the time of death, and other people who have HIV encephalitis, HIV-E, who we know have substantial amounts of HIV DNA, RNA, and protein. But again, there are these people who, the subgroup of people who despite dying, have almost no detectable HIV DNA, RNA, or protein in their brain, at least P24. And so Paula did additional analyses to look at the differences between these groups, which are not really quite the point of the talk today, so I'll just move on and show you these data, which are from about 600 people, 2,000 CSF plasma pairs, mostly collected by Dr. Ellis over the years. And we measured HIV RNA in them, and the blood HIV RNA is shown in red, CSF in blue. And we know historically that HIV RNA in CSF is about 1.5 logs lower than concentrations in blood, and that's what we see here. What we didn't expect to see was that about a quarter, 23% of people have HIV RNA in CSF below 50 without any therapy. These are all people who are off therapy. And Mattia Trunfio, who's working with us in San Diego, who is originally from Torino, working with Andrea Calcagno there, has been analyzing these data and made this very nice graphic here showing the correlates of this, including greater CSF serum albumin ratio, an indicator of blood-brain barrier permeability, higher plasma RNA, and so on. But also factors like lower HIV RNA in CSF with having had 3TC exposure and other factors. Again, not entirely the point today. I'm happy to discuss those further, but I want to move on. So when when someone is on antiretroviral therapy, so the CSF data I just showed you were people who are off therapy. When someone's on suppressive therapy, we can still measure HIV RNA, but levels are often below the lower limit of quantification of the commercial assay. And so we can use single copy assays, and this is an analysis that we performed with Bert Anderson, looking at data generated for us by Daniel McLernon, who was also one of my early mentors in the lab when I was at Duke. And we found that, not surprisingly, the longer that someone was on antiretroviral therapy, the lower the level of HIV RNA using this single copy assay, and that these very low levels of HIV RNA were associated with worse performance in some cognitive domains, but not all. Serena Sputic and Kevin Robertson also analyzed data but from the AIDS clinical trials group and looked not only at the cell-free HIV RNA, but also at cell-associated, or CA here, HIV RNA and cell-associated HIV DNA, showing that it wasn't the cell-free HIV RNA that was present in very many CSF specimens. It was actually the cell-associated HIV DNA, and that this was associated with worse performance on neurocognitive testing. So this pointed toward a role for HIV even when people were on suppressive therapy. Indirectly, that was supported by this clinical trial that we recently published from the ACTG 5324, in which people were randomized. They were on suppressive therapy, and they were randomized to intensify their regimen with either dual placebo, dolutegravir plus moraviroc placebo, or dolutegravir plus moraviroc. And all of these people met criteria for cognitive impairment on neuropsychological testing. And so what we found over time was that there were no differences between the arms in global neuropsychological performance, and also which improved due to learning and practice, and also no difference in Beck depression inventory or depressive symptoms over time. And so what this indirectly points to is it's not a problem with low-level HIV replication, because intensified therapy should have stopped that. It might still be a problem with just transcripts and with protein without the presence of viruses, which intensified therapy would not alter. And so Dr. Brew's group, working with Kazuo Suzuki, has shown very nicely using a new, more sensitive assay that cell-associated HIV RNA is present in almost 90% of CSF specimens, and that it differs between different regions of the brain: frontal white matter, posterior cingulate cortex, and caudate. And so these are very nice data that reinforce the idea that these transcripts are continuing to be produced in people who are on suppressive therapy. Avi Nath and others, using specimens from us and other people, have measured the HIV protein TAT in CSF and plasma specimens as well, and found that during suppressive therapy, it's present in about 37%. As Charlie said, you look for opportunities. Some of our opportunities that we followed over time have been in the drug abuse area, and particularly methamphetamine and cannabis. And Dr. Nath showed in this group that, that this group was overrepresented for cocaine users. They also found associations with a couple of cognitive domains, speed of information processing and motor functioning. And they showed that with therapy, while there was some people who had a dramatic reduction in TAT after starting therapy, there were some people who increased their TAT concentrations in CSF after starting therapy. So again, these are indicators that HIV is still contributing. And you guys have heard me talk perhaps before about the more pharmacologic focus of mine. In this case, more pharmacodynamic, in that it has to do with the effects of therapy, the neurotoxicity. But we know that there are data now that well support the neurotoxicity of efavirenz. We don't use that as much. With protease inhibitors, these are findings showing carotid intimal media thickness being worse with protease inhibitors. Soon, a neuropathologist who used to work with us and is retired now, but soon used also brain tissue from the NNTC, the National NeuroAIDS Tissue Consortium, and also found thickened vessel walls, blood vessel walls, in people who were taking protease inhibitors at the time of death. And then yesterday I talked about some of the data from the Netherlands and Germany, and the data I showed you yesterday on dolutegravir. So when we're thinking about neuropsychiatric complications, we have to think about not only the virus, but the medications we use. Inflammation, particularly germane to this session, inflammation is also important. Priscilla Hsu and David Waters published a very nice review, and they show that there are several indicators of inflammation that are associated with cardiovascular disease, including IL-6, high sensitivity CRP, soluble CD14, and an indicator of thrombosis, a D-dimer. Alan Tenorio also published a very nice analysis that also found some of these same biomarkers, as well as this antiviral cytokine or chemokine, being associated with cardiovascular disease. So we know people have persistent inflammation during therapy. We know that that puts them at risk for end organ complications, and these are just some of the data that support that. Ahmed Tawakkol also has done some beautiful PET imaging of the heart and the aorta using FDG PET. And what this shows are just a summary of some of his work looking at the aorta and the heart in people with HIV and without HIV. And the brighter signal indicates evidence of more inflammation in the walls of the aorta or in the heart. And you can just see that between people with HIV, without antiretroviral therapy, there's clear differences here in the amount of inflammation. His team also looked at the differences between people off antiretroviral therapy and then transitioning on to therapy. And what you can see here is that before therapy, there's substantial evidence of inflammation, this bright signal in lymph nodes, less so in the heart. After therapy, the signal greatly diminishes in the lymph nodes, but actually increases in the heart. And they saw that the signal correlated with an indication of myeloid inflammation, which also correlates with soluble CD14 that I mentioned on the prior slide, soluble CD163. And Trish Burdo from Temple, working with Dr. Ellis, did some beautiful work looking at soluble CD163 and found that it was elevated in people with cognitive impairment in HIV, particularly and relevant to a later session today, particularly people with symptomatic cognitive impairment. And Jennifer McGuire from Penn also looked at this and correlated with it with another indicator of neuronal injury, axonal injury, particularly neurofilament light, or NFL. So again, reinforcing this connection between inflammation and nervous system injury and heart disease. So people with HIV, as we know, are at greater risk for multiple diseases than people without HIV. This is a beautiful analysis from Rasmussen et al. That shows in each of these panels a different disorder with the age along the x-axis and the incidence rate for people with HIV in the red line, people without HIV, typically in the line that's lower, and the incidence rate ratio. And what you can see is that, of course, many of these go up with age. They are aging-related comorbidities. Often the people with HIV is higher than the people without HIV, but over time, as the people without HIV catch up, the incidence rate ratio declines. And even though it does decline with age, you can see in some cases, like for stroke and for cognitive impairment, that it remains relatively elevated, but it does, the difference narrows some as people get older. And then this graph was shown yesterday by someone else, an analysis of multimorbidity. These conditions don't always exist by themselves, in solitary, but they exist many times together. So data from the Netherlands and from Denmark have shown that people with HIV are more likely to have multimorbidity. Dr. Giraldi, who's very involved in this workshop, has shown that many times as well. So we performed the Charter Aging Project with support from NIMH, and we brought people back 12 years after their initial comprehensive evaluation and assessed them again. And a lot of work went into bringing these over 400 people back after 12 years. Locating some of them was a challenge. And overall, we found that the substantial majority of them remained stable or improved, but about a quarter of them declined over that period. And an important question, which we didn't answer, is whether this is more than in the general population. But we used an assessment that was based on a normative population of people without HIV. And we think that this is more than in the general population, but it's always stronger to have a direct comparison group. We looked at the correlates, the things that were associated with cognitive decline over 12 years, either at the baseline visit or 12 years later. And I won't read all these off, but you can see that these are risk factors for cardiovascular disease, insulin resistance, and not a risk factor for insulin resistance, but insulin resistance actually, lung disease, and depression, among others, as well as some signal here for substance use. So this highlights the challenges of identifying what the phenotypes are of people with HIV, because not all of them have all of these conditions, of course, and so tailoring or personalized medicine when we get into the clinic to identify which of these are affecting our patients and which can be managed is important. So Priscilla Hsu and Felicia Chow have also done beautiful work looking at stroke. Felicia's really one of the world's leaders in this area. And she's published a lot, but some very nice work that she's done and the MaxWise and other studies has shown that, women have about, women with HIV have about twice as high incident rate of stroke as men with HIV, and this is particularly true for younger women, and that non-Hispanic black people have about a 3.5-fold increase incident rate for stroke than do people from other races and ethnicities. So these are important findings, and Priscilla's also used a similar approach. She's done vessel wall MRI as well as FDG PET, which is what these graphics show over here, like Dr. Tawakol has done in the heart, and looked at the carotid and at intracranial vessels, and has very nicely shown, just showing here, that there is inter-individual variability. Some people have higher levels and some people have lower levels, and she's shown, among other things, that people who have higher levels are more likely to score high on stress questionnaire, and creating a link between stress and cerebral vascular disease, subclinical cerebral vascular disease. And there are other data I'll mention Jessica Castillo, who's also published in this area, and apologize for her for not showing her work in this area. But this very nice work from Emily Heil at Croy earlier this year looked at anxiety and depression and showed that they were associated with myocardial infarction over time using NA Accord data. So NA Accord is a very large database and a collection of cohorts, and you can see the substantial power that these analyses have in these sample sizes. And in this group, there were about 500 type 1 MIs, myocardial infarctions, which I define here, and about 374 type 2 MIs. And she found that depression was associated with type 1 MI and anxiety was associated with type 2 MI. So these are, again, another important link between neuropsychiatric disorders and cardiovascular disease. What we find at any site can vary substantially, and this is just a graphic that I made up of the 6 charter sites from the west coast of the U.S. to the middle of the country to the east coast, and I've just color-coded them for the ones that tend to have higher values and the ones that tend to have lower values. And in the interest of time, what I wanted to just point out here were the substantial prevalence of lifetime major depressive disorder and lifetime substance use diagnosis, but the pattern of substance use differs from site to site. On the West Coast, we prefer our methamphetamine. On the East Coast, they tend to prefer cocaine. And in the middle of the country, they don't have a strong preference for any sort of any of the major classes of addictive drugs. So, but it's important when analyzing data to consider how these different drugs affect the nervous system, and it's something that takes attention and is not always addressed in as much detail as we'd like. And to be fair, we don't always do it either. With our focus on methamphetamine, we've looked at this indicator of biological aging, telomere length, and shown in a study that had people into 4 groups: HIV, no HIV, methamphetamine dependence, no HIV dependence, and showed that having either one or both resulted in shorter telomeres with age here on the x-axis, and that when we use that to estimate the age deficit, if you will, either of these, either methamphetamine, HIV, or both of them together, tended to shorten people's lives, basically. And particularly relevant to today's discussion, we also found that this is showing unadjusted correlations, but even after adjustment, these persisted, with shorter telomere length being associated with Framingham, cardiovascular risk, with stroke risk, with frailty, and many other things. So again, in the interest of time, I will move on. Kalen Peterson's work was mentioned yesterday, and he's really done beautiful work working with Sarah Cooley and with Bo Ansis. And Sarah had a nice poster yesterday on the brain age gap. And Kalen, as you heard yesterday, has shown that that people with HIV have essentially older brains, so consistent with our area of focus. He's looked at structural MRI. He looks at structural MRI to determine that, and he found that the larger brain age gap was associated with these differences, including more white matter hypointensities, which is an indicator of vascular disease. So again, a link there. And he also found when he uses very nice approach to identifying the most efficient model, the one that explained the most variance with the fewest number of covariates, he found that larger brain age gap was associated with male sex, with greater Framingham cardiovascular risk, and relevant to the point I made earlier about social and structural factors and the discussion yesterday with area deprivation index. So polypharmacy is also important. This is a very nice summary from Amy Justice. I just direct you to it to think about the mechanisms of harm from polypharmacy. We've got funding from NIA to look at this with Chin Ma and Hopkins, and Raha Daskeb has been analyzing these data for us to look at different patterns of neuropsychological performance, and then patterns of concomitant medications, non-antiretroviral medications, and Laura's giving me the eye here to finish up, so I won't go on, but this rotated component 1 down here seemed to be particularly important, and perhaps not surprisingly, it includes CNS drugs, psychotherapeutic drugs, anxiolytics, and others. But it's important to document this and then to be thinking about it, about deprescribing when people come into the clinic. And so we've also been looking at different patterns of not only neuropsychological performance, but these phenotypes or clusters involve depressive symptoms, cognitive symptoms, and everyday functioning, and finding that, as was mentioned yesterday, about half of the people are in this healthy group, so that's a good sign. There's a group of people who have mild cognitive impairment, but with moderate depressive symptoms, but not so bad cognitive symptoms or daily functioning. But this group with more moderate cognitive impairment and substantial depressive symptoms, substantial cognitive symptoms, and substantial worsening of daily functioning. And another group that has a similar degree of cognitive impairment but has none of those other factors are doing very well. So this is just showing the pattern in a different way, and these are showing changes over time. This is an active area of investigation, but it's something that the field is moving toward to better understand this. So in managing atherosclerotic cardiovascular risk, I just put this here for you to refer back to. It just highlights it's from outside the HIV field, the cardiovascular field, the issues that cardiologists try to address in the clinic to manage someone's cardiovascular risk. I thought I would just mention in terms of therapeutics, ruxolitinib, these very exciting new findings that were presented in Brisbane, that this drug can reduce the HIV reservoir in people with HIV who had a high baseline reservoir. And so when thinking about the contribution of that integrated HIV DNA and viral products, this could be promising in the future. The data from Reprieve recently came out too. This trial of pitavastatin was stopped early for efficacy, good news, because it reduced major adverse cardiovascular events. And then finally, I mentioned deprescribing, so these are just a couple of graphics that you can go to these articles and review for use in your clinic. So I'll just end with this slide about prioritization of key components of care from Dr. Erlandson and Karras, that the 6 M's to think about when managing people in the clinic. And the important one here I've highlighted on the side is that these are all modifiable. And we'll just end with some questions that we can think about in the discussion later. And with that, I will end, and thank you for your attention. Recognize Bert here again, and that's it.
Yeah.